name is Angelica Slate. My fellow group members are listed here and they will definitely get a chance to speak. Iffy, who is mentioned, she's third on that list. She will not be here, but she participated as well. So we are presenting all of our work today. We would like to talk to you guys about women in labor during this coronavirus pandemic. It's a huge issue. It's not always talked about. I think a lot of women's health issues aren't always talked about. So this was one that we chose, and we found that it was specifically interesting to us, and Clea was the one that chose that for us. So we are very grateful to her for this great topic. So a little intro, obviously because of recent coronavirus changes to in-hospital births, a lot of women struggle with their options, whether they're gonna give birth in a hospital and have restrictions or whether they're going to do at-home births. Today we will discuss some of those restrictions and some real-world examples of not just mothers and families, but also of healthcare workers, because they are going through a lot right now, and that is a perspective we wanted to shed some light on. And for table of contents, we're going to talk about mothers and families first, and then we're going to talk about healthcare perspectives towards the end. So yeah.
All right, hi everybody, I'm Clea. So thanks for the intro, Angelica. So pretty much the background, the changes that have been happening because of COVID is that a lot of cities and states in the US have put in new hospital regulations that limit the number of people who can be in the delivery room. And for some places, that means only the mother is allowed. So as a result, because a lot of mothers do not want to give birth alone, as it is a very emotional time, and it'd be nice to have loved ones with you, or even a doula or midwife with you that you are comfortable with, they are having to make the difficult decision of whether to give birth in a hospital alone or shift to a home birth, which is often unmedicated and has its own risks because a lot of times in emergency situations, home births don't have the tools that are needed to help for those dangerous labors. And also, some hospitals are requiring mothers to wear masks all the time, which is not a fun situation to be in if you're in a stressful labor situation.
Okay, so hi everyone, I'm Veronia, and I'm going to talk about the implications that mothers have faced due to the COVID-19 as their due dates get closer. So one of the most common decisions that are now being made by mothers is whether or not they decide to have a home birth or go to the hospital. And at-home births are, like Clea said, unmedicated, and there are less resources if complications arise, and that also takes me to the second point, which is the lack of immediate access to health professionals for prenatal care. So now OBGYNs are recommending that their appointments become more spread out, and if they're not needed, to just not schedule them in the first place. And this third one would be exposure to disease can lead to the separation from their child. So if there are confirmed COVID-19 cases in the mothers, then the physician will recommend them to enter a period of quarantine between the mom or any of the other caregivers in the network of the baby in order to decrease risk, because so little is known about the transfer of mother and baby for COVID-19.
So one public example of this situation is this woman who has been publicly open about her experience where because of COVID pandemic, she decided to have a home birth, but during the birth, her child suffered from shoulder dysplasia, which is a condition that can only be effectively treated if you're in a hospital with a doctor that has the correct tools to fix it. And unfortunately, the baby did pass away. So the mom has been publicly speaking about her difficulty coping with her decision to have a home birth versus the hospital birth because she didn't want to be alone.
And my personal account would actually be my cousin that had a birth in the hospital of her new daughter. At 35 weeks, she began monitoring the movement and took a blood test to see if there was any abnormal chromosomal abnormalities in the baby, but everything seemed fine. But at 37 weeks, she presented with having severe stress and early onset contractions, which eventually faded away. but at 38 weeks gave birth, which is considered full term, but still gave birth a little bit early. And with her baby is perfectly healthy now, is just receiving a lot of like bed rest, is breastfeeding. But after giving birth, she did have high blood pressure, which was a concern to her physicians because they were afraid of postpartum preeclampsia. And with the meditation and having the baby close, the high blood pressure eventually went down. So there are some considerations for the mothers postpartum, which would be to manage visitor access during hospitalization and even at home, because you want to make sure that the baby is safe. So just narrowing down the circle of people that are present during labor is really important. Discussing separation options, which would mean entering a period of separation between the mother and the baby. If not, the mother doesn't have to separate if she isn't suspected for COVID-19. And persons with COVID-19 are recommended to have separation between the baby just because of the little that's known. And then mother-baby contact would be that if there's no other healthy adult present in the room to care for the newborn, a mother who has confirmed COVID-19 should put on face masks and practice the regular hand hygiene. And hospital discharge postpartum for women should follow recommendations by physician, but since still little is known of women with a higher risk of contracting COVID-19 pre or postpartum due to the amount known of coronavirus, but it is still important that they take the extra step of protecting themselves and their baby.
Yeah, so we've talked about mothers and family perspectives and personal accounts. Now I kind of want to bring it to healthcare workers. I put a quote on here from the New York Times article that I cited at the end of the presentation. And this quote, it seems a little glum, but I think it's important to talk about. So the quote says, "I'm not the kind of nurse that can act like I'm fine and that something sad didn't just happen." And I think a lot of times we think that healthcare workers can just go do their job and come home and they almost have two separate lives and they can separate that completely fine. But a lot of things happen in these hospitals, especially with COVID-19 happening, and a lot of nurses aren't okay. And so just to kind of describe that a little bit. I think it's a shared struggle that a lot of them kind of face together and a lot that we don't know about as outsiders. It has been said that they are more susceptible to PTSD, burnouts, and even suicide, especially in New York hospitals. And we know New York was hit very heavily because of the coronavirus. They are also, according to the World Health Organization, the most vulnerable to mental health problems. And so some studies in China, Canada, and Italy found soaring numbers of anxiety, depression, and insomnia, and that's especially in women healthcare workers. And as part of the women's health and gender empowerment, that is very important to point out for us. They coined this term that I wanted to describe here called betrayal trauma. And while I never heard of it previously, I think it's something that's very new to society. They're describing it as the feeling of being overwhelmed and abandoned while rarely acknowledged for heightened demands of jobs. And this is specifically for healthcare workers. So it's almost like a form of trauma is being created for them that now they have their own name for it. And I think that's very unfortunate. And while it's really important to address, it's just unfortunate that it's happening to them. So I wanted to give two personal accounts. The first one is of a woman named Christy Alderson. She is an oncological nurse at a hospital in Indiana, and she's also 38 weeks pregnant, or was 38 weeks pregnant. And she was a high-risk pregnancy, not just because she's 41 years old, because she was a female nurse dealing with the coronavirus situation. And the following personal account that I'm going to talk about was her OBGYN that also worked at the same hospital, but the OBGYN quoted, "Women are more likely than men to be healthcare workers and have a higher chance of contracting the virus and acting as a focal point to spread it. So unfortunately, because of this, she was forced to take leave 3 weeks earlier than she initially planned. And while this might seem great, now she gets 3 weeks more of vacation, she was actually pretty bummed out about this, and mostly because she wanted to make an impact and she wanted to help during this time, but obviously she couldn't do that." So this brings me to Dr. Caitlin Bernard. She was her OBGYN. She is a doctor at the same hospital in Indiana, and she's also an assistant professor at Indiana University School of Medicine. She discussed there's like a lot of unknowns with pregnancy and COVID-19, which makes it such a bad situation. Severity of symptoms can vary. Passing of the virus to the child is fairly unknown. And the mother being hospitalized is kind of case by case. So it's hard to keep them in hospitals or require pregnant mothers to go to hospitals for appointments and births. But she also stated a lot of things about OBGYN and reproductive health continue just as if there was no pandemic. People become pregnant, they progress through pregnancy, and they deliver babies, which is hard for us to understand because we hear of the issues going on with COVID-19, but we don't think that these natural states of giving birth are still happening, and there has to be some way to address it. So it's almost like a comfort level is missing for these mothers.
Hi, I'm Sunny. I'm going to talk about the effects of COVID-19 on maternal health, and this is going to be focusing on lower resource settings or LMICs. And amidst this pandemic, we want our healthcare system to be responsive, and also we want to ensure the quality of care mothers receive. We know that weak health infrastructures are causing a lot of direct and indirect maternal mortality. And because of this pandemic, this worsens health problems endemic in many areas, such as HIV, tuberculosis, malnutrition, and frequent outbreaks of viral infections. And with this pandemic happening, mothers are more susceptible of viral infections, and their chronic diseases are not as well managed. And reduced coverage of essential maternal health and child health services, along with food insecurity issues, are causing a high prevalence of wasting among mothers and children. And when I talk about essential services, I mean distribution of antibiotics and also basic things like having clean birthing environments. And this is a very big thing, considering how resources are already constrained in these areas. The pandemic is worsening the conditions. And like we have previously mentioned, fear of the unknown and extensive misinformation is further burdening the slow progress that we have made on maternal and child health. And some predictions even said that this will reverse the progress that we have made in the past 20 years. And I'd like to draw your attention to person-centered maternity care, which is not only, it's more than providing mothers with comfort, but it is assuring their basic human rights. So we want mothers to give birth in an environment that is free of physical or verbal abuse, and also we want them to have the support they needed. So communication is very important in this matter. And with the pandemic happening, it's very hard for mothers to access services and communicate with healthcare workers. And one thing that I'd like to highlight is, I believe, as Clea mentioned, is that a lot of mothers are left alone or unsupported during labor. This is why some mothers in the States opt for home births, but in resource-limited settings, home births are probably not one of their best options or are basically just unavailable. So this put mothers at a very vulnerable state, having to go through the birthing process alone. So experts are trying to call for attention to include person-centered care and provider trainings, and also trainings for providers that provide them with coping mechanisms to help them, to support them through this pandemic and to ensure that their well-being is also considered.
And that's all we have for you guys. The first resource up here is the CDC, which I think is a great resource for anyone to go to if they want more information about this. But yeah, that's it.
Can everybody see the screen?
Yes.
Yes. Okay. Hi everybody. So I'm Anshika. I'm from the UC Davis campus, and I'm here with
Nilpa Shah from UCLA.
Andrea Delgado from UC Riverside.
And today we're just going to be talking about urbanization and its effect on health. And so just to give a brief outline of everything we're going to be going over today. So we're just going to be giving a quick introduction of what urbanization is, and then go into its impact on planetary health, physical health, and mental health, and then talk more about recommendations that we have or have found through our research that can be implemented to help solve the issues that urbanization has on these different levels of health.
Okay, so in general, urbanization is the movement of people into urban areas influenced by the shift to an industrialized economy. So with urbanization, there are changes to living standards as a result of increase in movement of people into these areas. So there's an increased
We
migration.
can see your presenter notes. Sorry to interrupt, just in case.
If you put in display mode, then you won't see all those notes, and we'll be able to see your slides better.
Okay, let me try that.
So just share the slides and then click on the display like you do for a normal. There, perfect, perfect.
Okay, so I'll just continue. So pretty much there's an increase in movement from rural populations to urban areas because of the fact that there's greater advantages in urban areas. For instance, there's greater access to jobs, education, healthcare services, mobility, as well as social integration into communities. So urbanization is also considered an emerging global public health threat as a result of potential health risks and hazards. So in regards to the environmental justice concerns, the greatest risks are to the poorest populations of people who actually contribute less to greenhouse gas emissions and those who are undergoing rapid economic development and urbanization. So low-income communities are vulnerable to poor housing construction. They have less access to services and environmental regulation in general, and they undergo greater ecosystem degradation as well. So in general, social inequities and poor disaster response worsens health impacts while increasing their vulnerability to climate change.
And here's just a graphical representation that shows the increase of urbanization in our world. And the United Nations estimates that by 2050, more than 2/3 of the global population will be living in urban areas. So clearly it's a pretty important topic to look into because it's going to be part of the majority of the world's lifestyles.
Okay, so just to touch on planetary health, planetary health is evidently threatened by urbanization. Planetary health is extremely important since it also influences human health. And as you can see in the pictures, you can see how over time urbanization is being witnessed with a greater, is being seen more often than before. So urbanized areas are greater consumers of food, energy, water, and land as compared to rural populations. So these consumption patterns, they increase greenhouse gas emissions that contribute to the issue of global warming. Similarly, direct environmental degradation also displaces effects on ecosystem services. And overall, the stresses caused by urbanization places a pressure on food systems, water supply and quality, and the need for sanitation. Increasing population densities also contributes to the emergence of new infectious diseases as a result of the quicker spreading in cities due to increased person-to-person contact, as can be seen with COVID-19.
So some of the other health, physical health issues that we can see with urbanization is that there's an increased violence, injuries, and also other chronic illnesses that can happen in people living in urban areas. Some examples are hypertension, heart diseases, diabetes, or chronic respiratory diseases. About 7 million people die each year around the world due to urban air pollution. And the main contributor for this air pollution is motor vehicles emissions, industrial pollution, electricity generation, and household fuel combustion. And the main reason for death is cardiovascular diseases or respiratory diseases. For example, an example is tuberculosis incidence is much higher in urban areas. For example, New York City has about 4 times the national average for tuberculosis incidence. Some reasons for this disparity between urban and rural areas is because of a bigger food promotion, unhealthy food promotion in urban areas, which is the food that's advertised is very quick and cheap, and also has a lot of sugar and sodium levels. Another physical health outcome that we see for urbanized areas is also less access to areas to exercise. Also, some of the reasons is that urban industrial jobs do not require a lot of movement. Also, there is high amount of traffic on the roads in urban cities and a lot of heavy use of motorized transportation. About half of the traffic-related accidents that are happening are usually to pedestrians and cyclists, or even two-vehicle motorized drivers. So this makes urban areas and urban cities very unsafe for people to exercise outside. And also another reason is poor air quality as well.
So the same downsides of urbanization that can affect our physical health also affect our mental health, which is equally as important. So in the next few slides, I'll be going through how urbanization can impact our mental health. So there are various ways in which urbanization can negatively affect our mental health, but for the sake of time, I'll be focusing on one, urbanization creates divide between socioeconomic classes, and 2, the focus of other public health issues due to urbanization in cities can often take away from addressing mental health issues in those same cities. So urban populations create divide. So gentrification, which is associated with urbanization, can cause homelessness or people having to live in poor conditions such as slums. And living in constant poverty can cause many to get in a constant state of anxiety. For example, you may not know where your next meal is coming from, or you may not know how you're going to pay bills in such an expensive city. And so just a case study that kind of gives an example of this topic is a case study that was done in Brazil by researchers from the London School of Hygiene and Tropical Medicine. And so this study found that in Brazil, urbanization favored growth in the low-income parts of Brazil's major cities. And so over the past 10 years, while the city of Rio de Janeiro had a growth of about 3% in the last 10 years, in other areas of the city, their slums had actually increased by over 30%. And so those living in these areas are often missing out on education due to, for example, cost or travel issues. Another example is the youth being vulnerable to illegal or dangerous activities such as drug trade, and all of these ultimately can really negatively impact your mental health. Next slide. And another thing to touch on is that having a focus on other public health issues such as hygiene and sanitation often takes away from mental health issues. So just another case study, in 2011, it was found that India only spent about 0.06% of its health budget on mental health, which is a lot smaller than other developing countries who spent about 4% of their budget on mental health. And this is a really common pattern for other developing countries because they have to focus on a lot of other health issues such as hygiene, water, sanitation, and all of those things which are impacted by urbanization. And so those are given more of a focus. Similarly, Nigeria has a clear mental health crisis. They have about a 9.5 per 100,000 people suicide rate, and because Nigeria has so many other health problems that are the leading cause of death, such as HIV, stroke, heart attack, heart disease, those are given more of a focus than mental health issues. And so that just kind of shows that it's harder to address these issues in bigger cities. And unfortunately, what's happening is that although is that many of these physical issues take a toll on mental health, and vice versa. Having poor mental health can result in poor physical health. And so there's just this constant cycle in cities with the high prevalence of all of the above, but not being able to address them all. And so, as we briefly mentioned before, by 2030, 2/3 of the world's population will be living in cities. And so it's really important to think about how we can address the current situation and prevent it from getting worse. And so we'll be concluding with those recommendations, but just with a focus on mental health. Some ways that we can achieve these goals are, one, by having better economic policy. There should be more coverage for mental health services and providers. Another one is to really destigmatize mental health in a lot of these communities, and also having more resources of support and having more of a sense of support and maintaining a sense of community in these bigger cities where that's often hard to find.
Some other solutions that we are recommending is that we have sustainable development and management of urban growth in these areas, and also integrating policies to improve existing economic, social, and environmental ties. Moreover, we need to, as a community, try to minimize environmental degradation, and also share benefits of urbanization, such as access to infrastructure and social services to all. Moreover, we should focus on the needs of urban poor and vulnerable populations for housing, education, healthcare, and safe environment. And the situation currently we have with COVID-19 presents a viable possibility for urbanized areas to coexist in a society that is conscious of both planetary and human health.
Talk about human actions that lead to disease emergence with a focus on the current pandemic. We'll also discuss how disease emergence connects to global patterns in urbanization and where certain human populations are disproportionately affected by acute diseases.
Okay, so I'm going to start us off, and maybe the term Anthropocene is new to some of us, so I'm going to start there. The term Anthropocene is an unofficial unit of time used to describe the most recent period in Earth's history where human activity started to have a big impact on the planet's climate and ecosystems. But how is this linked to the current pandemic? Well, we need to think about what kind of human activities facilitate the emergence of infectious diseases. We know that zoonotic diseases are a huge public health challenge, and they represent the majority of emerging disease threats. Humans influence at some level the emergence and/or transmission of practically all zoonoses. When we talk about urbanization, we're talking about the process by which towns and cities are formed and become bigger and bigger as more people begin living and working in these central hubs. Urbanization impacts our environment in many ways, but I want us to think about how humans encroach on wild spaces and develop them for human use, and that doing so displaces and disturbs wildlife. The top image is showing you the loss of once wildland that's now being developed for human industry. And this bottom photo is a real picture taken in Mumbai. The takeaway here is that when humans invade, we change this land and force interactions with species we wouldn't normally be coming into contact with. We don't just see this in Mumbai, we have to remember that we have similar issues here in California with our wild mountain lion populations. So let's think about a specific example. If I can. Oops. There we go. How does habitat conversion in the name of urbanization set us up for a global pandemic? So bats are suspected to be the origin species of SARS coronavirus 2. If we keep leveling natural habitats where bats live and instead build homes and structures along this urban-wild interface, which is there in the dashed yellow line, we're creating new spaces where bats may rest, find shelter, and roost. And bats are not likely to transmit pathogens to humans when they're in wild habitats, but land conversion and dense human populations have increased their exposure to other species and to humans. Aside from setting up this kind of perfect storm scenario where a novel disease could spill over, urbanization keeps impacting human populations once the spillover has occurred. For example, urban cities are more densely populated, and are hubs for travel and trade. And although they have more opportunities for healthcare, not everyone is able to access it.
So now we're going to tie in urbanization to the social determinants of health. So disparities in healthcare are often exacerbated by urbanization. And to understand this, we need to think about the social determinants of health. Urban populations face a higher risk for infectious disease transmission due to crowdedness, lack of sanitation, etc. And individuals of low socioeconomic status and minority backgrounds are much more likely to live in these urban areas and therefore more likely to access healthcare insurance. These communities rely on safety net care with limited access to the sort of preventative healthcare that could keep both chronic and infectious diseases at bay. So this sort of creates a double burden in these communities of both chronic and infectious diseases. So on top of the higher rates of both chronic and infectious diseases, chronic diseases like diabetes can actually damage our physiological defenses against infectious diseases like COVID, with data showing that individuals with diabetes are more likely to experience poor outcomes from COVID. So here you can see how we are gonna go into the impacts of urbanization with two case studies of two cities, one in the developed world, Detroit, and the other in a low middle income country that is India, to paint a picture of urbanization and the different forms that it comes through in. And so we'll see how there's many differences between these two cities, but also many shared issues that are closely linked to urbanization.
Hi everyone, my name is Jeremy from UC Berkeley, and so I'm going to talk about an article that I read called "The Blackest City in the United States is Facing an Environmental Justice Nightmare." So as many know, Detroit is known as Motown, but outside of the famous singers that came from out of the area, it is once known as Motor City. This city became known because of the automotive industry that happened during World War II, and it became one of the main contenders in the United States. Detroit actually held about 1/6 of U.S. jobs because they were ranked for number one in 40 hours a week jobs. And so a lot of people from the South were migrating to the North looking for these industry jobs and to escape the Jim Crow South and racist things that were going on within their neighborhoods. And so when the automotive industry took off, we began to see an extreme influx of air pollution. This increased a lot of chronic diseases like asthma, and some people experience juvenile diabetes. One of the interviewees in the article talked about how his brother developed it around age 5, and continued to have unfortunate health diseases and respiratory issues. And the young man also lived in an area known as Boynton, which is next to Marathon, which is an oil refinery in Detroit. And this oil refinery was actually fined in the early 60s with 15 violations of air pollutants. And over time, Marathon denied these accusations, saying that they have reduced their emissions by 75% over the past 20 years and only contributed about 3% of emissions into the area. And so what we saw was that these areas that were located near oil refineries and refineries were near areas that were predominantly Black. And a lot of these areas also host many citizens that had more chronic diseases. And so this is a quote that I pulled that I thought was really interesting about how Detroit is the microcosm of the national and global crisis of climate change, because we do see a lot of unfortunate air pollutants within Detroit area. This is just a small portion of what is actually going on in areas that are also industrialized. So as I mentioned before, the prevailing environmental concern is usually in areas usually located by zip code. And so this started early in the development of Detroit with ideas such as redlining, which segregated Black communities from white communities. And these districts that are continued to be Black communities have higher levels of air pollutants. About 71% of these areas are Black. And also in the article, the NAACP did a survey in 2017 that saw 2,400 children ended up with asthma attacks throughout the year, missing about 5 days of school. And their parents also had to take off to be able to care for their children. A lot of these children end up in the hospital for about 6 weeks. And so there are other air pollutants and contaminations that are happening within these areas that are causing cancer. And as we saw in the article, there are a lot of citizens, Black citizens specifically, that were suffering from cancer and dying due to the pollutants that they were ingesting. And yeah, next slide, please. And so what we did was I took a picture of Detroit and what we see with air pollution, and then I compared it to what we saw with COVID-19. And as you can see on the map gives you a kind of synopsis of areas that are heavily concentrated with COVID cases. And unlike New York, Detroit also had a large percentage of this Black community dying from COVID effects. And this is considered areas where most infirmaries are or where factories are that are releasing a lot of carbon emissions.
Hi everyone, so I'm Kalani and I'm a current MPH student from UCI and I'm here to talk about the second case study. So this is a picture from Delhi, India with a quote I pulled from an article in The Guardian saying that the air pollution there is a classic case of environmental injustice. Next slide, please. So for some background, India itself is home to 21 of the world's most polluted cities, and Delhi actually reached emergency levels throughout the region, with pollution reaching 50 times the level deemed safe by the WHO this past November. One estimate even stated that the pollution in India shaved 3.2 years from their life expectancies. And to put it in perspective, an article on Vox stated that breathing the air there is like smoking 50 cigarettes a day. And the WHO states that over 600,000 people die from pollution in India each year. However, not everyone is affected equally, and it primarily affects low-income residents living in poverty in dense areas with low access. Next slide, please. So the air pollution is a consequence of many factors, and these include climate and seasonality, as well as human factors like cars, construction, bad policy decisions, urban sprawl, high population density, coal use, and more. Next slide, please. Obviously, the urban sources of pollution, like traffic, construction, cooking fires, and more, they all increased as the population grew, allowing for unaccounted urban sprawl. And the combination of poverty, high population density, and poor sanitation makes these urban areas highly susceptible to disease. So what does this all mean in relation to our current events? Well, higher air pollution rates are actually linked to a higher COVID-19 death rate, making this region disproportionately affected, especially the low-income residents. And currently, the virus is revealing how unequal and unstable the urbanization process is in India and underscores the importance of addressing these issues. Next slide, please. So for some ways to reduce these issues would be to switch to cleaner energy, adopt better policies, better enforce these policies, and address the disparities that exist. To end, I just want to include a quote that I found to be very applicable to what's going on. The quote is, "It's like you're pouring a whole lot of stuff into a sink that's plugged up. It overflows with spectacular consequences." So with everything going on today, I just want to close saying that there's enough mess in this world. We need to start cleaning it up, addressing the issues, and collaborating with other people to find out new solutions to these problems, or they're just going to keep getting worse. Thank you.
Hello everyone, my name is Victoria and our group's project is on urbanization and climate change, and we're going to use a One Health model in presenting this topic. So, so far as part of UCGHI, we have been learning a lot about the One Health model and how this is a collaborative, multisectoral, and transdisciplinary approach that works both in different disciplines from animal, plant, people to environmental health, and how this is not only something that is happening in the community, but also globally, nationally, and how this is an approach that is helpful when we talk and look at improving health outcomes. And as a result, all people have the right to clean and healthy environment in which their communities can live, work, learn, play, and thrive. And towards this vision, the One Health model brings together a collective voice to develop an alternative agenda for environmental, social, and economic justice, and how this is basically a movement that is collaborative of all, and how we strive to make fundamental changes to economic and social institutions that will prioritize public good over profits and promote the right of every person to a decent, safe, affordable quality of life, and the right to participate in decisions affecting their lives. And this is another approach that I was able to see in one of the organizations that I've worked with, which was Asian Pacific Environmental Network, and how they use solidarity within the community in addressing both environmental and social justice issues. In the previous presentation, they talked about how socioeconomic factors could influence one's health. And one of this example of this model was applied when this organization was addressing some of the health issues that were happening in Richmond, California, which is located in the Bay Area. People of Richmond live within like 5 major oil refineries, like 3 chemical companies, 8 Superfunded sites, dozens of other toxic waste highways in the Chevron Richmond refinery, and most noticed that the demographic which within is mostly Black, which made up 20% of population, Asian 16%, and Hispanic or Latino is 41%. And how basically within this area, affordable homes for low-income residents are like right next to refineries and a cluster of other polluting businesses, and how California Department of Public Health has shown that residents of all ages in Richmond are 1.5 times more likely than those in the rest of the country to go to hospital emergency departments for asthma attacks, and how the community really strategized in addressing these concerns. And at the end of the day, they were able to work with the community in passing laws that prevent refineries from bringing in tar sands into the community, impacting the health of the people.
Then for urbanization, so urbanization refers, hi everyone, my name is Courtney. I am from UC San Diego. So urbanization refers to the increasing number of people that live in urban areas, and by 2050, 2/3 of the world's population are expected to live in urban areas. However, this creates fringe populations that undergo poverty and unhealthy living conditions, and urbanization leads to negative economic, social, and environmental consequences, such as poor air and water quality, insufficient water availability, waste disposal problems, and high energy consumption. And what that means is that urban environments can change the environment through consumption of food, energy, and water, where this now pollutes the environment, which affects their health and quality of life through urban population, and also affects their quality of life, such as respiratory infections and parasitic diseases. And one thing to note is that it's also not necessarily the size of the area of the urban area, but rather the patterns of the urban area instead. So just because the urban area is bigger doesn't necessarily mean it will create more pollution.
Hi, I'm Mina. Can you hear me? Sorry.
Yes, we can hear you.
Okay, great. Because I had like some technical issues with my laptop mic, so it has now been fixed because I'm using my cell phone. So I'm Mina. I'm a PhD candidate in geography at UC Davis. So I'm talking about climate change. and how it is related to urbanization and like these things that we have discussed. Climate change is referred to consuming fossil fuels and the excessive emissions of carbon dioxide into the air that have resulted in the high temperature in the earth. And so this has resulted many consequences. And during the pandemic and COVID-19, because people are driving less and the factories have going to stop and halt their activities, although there are less carbon emissions to the earth, but like these changes have been temporary because we are not also talking about the ecology, and governments are not giving priority to the plans that is related to carbon emissions and like climate change problems. And so we should think about how we can improve our climate change by educating ourselves and also other people. And there are also some movements regarding climate change, like children's movements, like Greta Thunberg activities that have been popular during like around the world, and also other plans that have been tried to improve the climate change. So, yeah.
And then all three are connected, which is One Health model, urbanization, and climate change, because population growth and human activities impact climate change. In Julie Siz's book, we learned in Environmental Justice in a Moment of Danger, she describes how social justice, environmental health, and human health are all interconnected, and how we often overlook how climate change impacts vulnerable communities, such as communities of color, those of lower socioeconomic status, and also developing countries as well. And we figured together as researchers, clinicians, educators, and global caring citizens that we can all work together in addressing environmental justice concerns that impact all of us.
And then we have a video that really showcases how important right now environmental justice and connecting it back to the One Health model is during this pandemic. So we're going to show a little bit of this clip.
We're not hearing the sound.
Oh, okay. Let's see. Maybe exit. I'm gonna just quickly go to YouTube because I don't think it was able to play through Google.
No pressure, Victoria, if your group also wants to transition to the next slides in the meantime, or if you just want to show a little bit of the YouTube clip, whatever is easier for you.
Sounds good. All right.
Still need to turn on
Are
the sound.
y'all able to hear it right now?
No, need to turn on the sound. It should play. We should be able to hear it if you click on the sound.
We can read the subtitles.
Yeah, or you can, and you can also put the link in the chat that we can pull up later. That's another possibility.
Yeah, I think I just got it to work.
Carrying the weight of the injustices that have been going on for decades. In this moment, right now, it makes us more susceptible to the coronavirus pandemic. Because if you have these underlying medical conditions, then that is a gateway for that virus to actually be able to impact what's going on because of the immunosuppressant situations that we find our communities in. You know, communities of color, lower income communities, and indigenous populations for decades have had to deal with toxic pollution. Everything from coal-fired power plants to coal ash pits to hog farms and turkey farms and chicken farms, incinerators. Communities of color, they've always been the sacrifice zones. They've been the places where we pushed everything that nobody else wants. And because of those exposures, there are a number of other factors that happen. And when you overlay the coronavirus with a community like there in Detroit, what you find is that you're going to have more and more folks who are being exposed and who are dealing with these infections. African Americans are actually getting infected at a higher rate, and they are losing their lives at a higher rate. But it's not just in the cities. You can go to Cancer Alley in Louisiana. Now, we know that New Orleans right now is one of the hot spots. And between New Orleans and Baton Rouge is an area called Cancer Alley, where folks, as far as the eye can see, there are petrochemical corporations that have been pumping pollution into their communities for decades and decades. Is nonsensical, because what it does, it creates or expands the sacrifice zones that we have in this country. It puts.
And basically from there, we would just want to conclude that the pandemic really shows a lot of these social inequities that is happening within our communities, but it's important that we address it together as health practitioners and also people going into public health and as a community together.
Okay, hi everyone. So we are going to be talking about missing and murdered Indigenous women and girls, and we thought that this was a very relevant and important topic, especially because the MMIWG Awareness Day was on May 5th. And my name is Bharti and I go to UC Berkeley, and I'm not sure if the others will also want to quickly introduce themselves.
Oh yeah, I'm Madeline.
Hello.
I go to Santa Barbara.
And I'm Jacqueline and I go to UC Merced.
So just a brief introduction. There has been violence going on against Native women and girls, which dates back to Spanish and Euro-American colonization of the Americas. And Indigenous women are often targets of violence and hate, and there are many reasons, and we'll go into this further in our presentation, but essentially some of the reasons include poverty, racism, sexism, and colonialism. And there is a mass movement to raise awareness about this pressing issue as well. So I wanted to show a quick video.
I've had friends whose relatives have disappeared. I've had
Is everyone able to hear the sound?
friends whose moms and grandmas have disappeared. And it's just been such a big epidemic. As a woman, you look out for, yourself and other women.
I think I am probably like a lot of non-Indigenous people who just are not aware. It's a real tragedy.
It's really important that we all get educated about MMIW, and once everybody knows about the issue, then we can start preparing to design relevant and applicable solutions to address
Can you guys hear me? Just testing. Okay. So as you could see, some of the most staggering statistics include that 97% of crimes against Indigenous people are committed by non-Natives. Native women are 10 times higher than the national average to be murdered, and one of the leading causes of death for Indian and Alaskan Native women is murder. Next. So according to the Urban Indian Health Institute, they were able to identify 506 cases across 71 selected urban cities. From those cases, 336 cases included missing and murdered women. Go ahead and go to the next. So furthermore, some of the factors of violence may include systemic causes that make these women vulnerable. This could be including low socioeconomic status, which research has shown to be linked to economic disadvantages, in addition to gender inequality, which continues to provide the society with a notion of devaluing women in general. Other factors could include a failure in the justice system. This could mean lack of further investigation, weak laws addressing violence against women. Overall, putting women in a position of high risk. Go ahead. Okay. So what does all this data reflect? Well, a lot of the data was collected through law enforcement data, and this is due to the Freedom of Information Act. So researchers were able to collect this data. 40 of the agencies they were able to reach out were able to provide some information. 40 of these agencies weren't able to provide any information, and 18 were still pending. So a limitation of the data that we were able to collect definitely reflects the lack of records and racial misclassification of Indigenous women. In addition, the report exemplified the lack of media coverage. So if these Indigenous women were covered in the media, most likely some of them were reflected with prejudice and improper data collection, and just also exemplify like the false idea that that these crimes are committed in the reservations, when in fact, like the report suggested, a lot of these also happen in urban cities. So most of this data did focus on the national inquiry into missing and murdered Indigenous women and girls, and also by the report of missing and murdered Indigenous women. So although there is limitations within the data that they were able to collect, we could see that the support and the advocacy of the women that have pushed forward were able to create these two big reports that were pretty much the foundation of this presentation. Yes, so this presentation just kind of like, this data kind of reflects the transparency and the most accurate data that we were able to find, and it was based mostly on these two reports.
So May 5th was named the National Day of Remembrance for missing and murdered Indigenous women and girls in the US, and this was made so in 2018 and is part of a larger effort that we're describing to raise awareness about the crisis. So in response to the crisis, Canada launched an investigation in 2016. It was by Prime Minister Justin Trudeau, called the Canadian National Inquiry into Missing and Murdered Indigenous Women and Girls. And the findings were recently released late last year and titled Reclaiming Power and Peace. And it was a 1,200-page report, and they interviewed hundreds of family members and survivors. And they also conducted a forensic document review, and the crisis was labeled a genocide. And there was also particular attention focused on two-spirit, lesbian, gay, bisexual, transgender, queer, questioning, intersex, and or asexual Indigenous people, and women who identify as such are also targeted for their identities. And so there are numerous recommendations, some of which included supporting Indigenous police services, changing criminal codes, and reforming child welfare. However, there has been some criticism from Indigenous activists, one of them being that there are no legally binding laws as a result of this report. So the question rises, how do we hold the Canadian government accountable for actually implementing change and ameliorating these issues. We can do the next slide. So the US has also responded in different ways. Late last year, Trump signed an executive order to create the task force on missing and murdered American Indians and Alaska Natives. So this included $1.5 million, which is allocated to hire missing persons coordinators, develop new protocols for cooperation among the different entities, and improve data collection. However, there's been criticism that there was a lack of input and consulting tribal leaders. And then also that we have Savannah's Act, which was inspired, or not inspired, but in 2017, Savannah LaFontaine Greywind, who was a 22-year-old pregnant member of the Spirit Lake Nation, was murdered, and this sparked national outrage. And so then this was introduced by former North Dakota Senator Heidi Heitkamp, and it passed the Senate on March 11th, 2020, and so now it goes onto the House for consideration. And so for the goals of this act include better coordination among tribal communities and local and federal law enforcement, and improving tribal access to law enforcement databases. And this hasn't been signed into law yet. So some more response includes activism and art. So there's the annual Women's Memorial March in Canada, which is held on Valentine's Day, February 14th, in Vancouver's downtown east side. And it began in 1992. There was a lot of outrage sparked by the murder of Cheryl and Joe. And so this march occurs every year to raise awareness about the crisis. And then we also have the Red Dress Project, which was started by Janie Black, who is a Métis artist from Canada. And basically, as you can see in the picture, it's red dresses hanging up, and it's a really striking, eerie image. And it's supposed to represent the thousands of missing and murdered Indigenous women. It's a public art installation, and there's some installations in the US as well. And the artist said that red was chosen because the color, quote, relates to our lifeblood and that connection between all of us. And it was started in 2000.
Okay, so how can we all support the MMIWG? Well, we could begin by understanding the impacts of all violence, which are caused by systematic complex issues. So the beginning step is to really understand kind of like the historical, political, social, economical, and institutional causes of violence towards these women. In addition, we could all encourage policy actions that address and reduce violence. Furthermore, we could ensure that funding continues to support national and regional Indigenous organizations. And last but not least, we hope that this presentation kind of spreads awareness on this topic.
And then also Alexis pointed out to us that there are a lot of great organizations that are trying to support these efforts, one of which is the Coalition to Stop Violence Against Native Women. And it's an organization that was founded by 3 Native women, and they offer various support for Native advocates who are fighting to end violence in New Mexico's tribal communities. So they provide a lot of great resources like training, community support, book drives, policy advocacy. And so if anyone wants to contribute to their efforts, you can donate to their organization, and there are also a lot of really great organizations. But yeah.
Thank you guys.
Hi, I'm Manya. I'm from UCSC, and I'll let my other group members introduce themselves.
Hi everyone, I'm Brianne Hernandez from UCLA.
Hi, I'm Sarah from UC Davis.
I'm Victoria from UC Berkeley.
And we wanted to explore what abortion access looks like during a pandemic and what telehealth medicine and telehealth abortion access looks like.
Okay, so to introduce this topic, I want to talk a little bit about abortion rights. So the right to and the access to abortion has been a public health issue and constant legal battle in the US since the early 1900s and was further intensified after Roe versus Wade. So abortion continues to be threatened during the pandemic, where anti-abortion organizations and politicians are using the pandemic to rationalize further restrictions. So even though every state has taken action to declare a public health emergency to mitigate the spread of COVID, several states use the pandemic to specifically define abortion as non-essential or an elective health procedure, and to ban abortions until the end of the emergency. However, recently the World Health Organization reaffirmed that abortion is a time-sensitive and essential medical service, and that a delay may increase the risk or potentially make it completely inaccessible. Next slide, please. So I wanted to talk a little bit about anti-abortion violence. So anti-abortion violence has largely been discussed in the context of community violence, meaning violence between individuals who may or may not know each other. So this includes violence against clinics, providers, and patients. In the National Clinic Violence Survey conducted by the Feminist Majority Foundation, anti-abortion violence activity was tracked across the US and found that anti-abortion organizations largely contribute to this type of anti-abortion violence. So organizations include Operation Rescue, Created Equal, Army of God, Operation Save America, and many others. Next slide, please. So what's not so commonly found in the literature when defining anti-abortion violence is examining it in the context of structural violence, meaning systematized state actions by politicians intended to shut down health clinics. So since COVID was declared a pandemic in March by WHO, a number of state actions to suspend abortion has impacted several clinics across the country, including, next slide, please. Alaska, Iowa, Kentucky, West Virginia, Louisiana, Mississippi, and Texas. So other states have used COVID to ban abortions, but they were blocked by a judge, including Alabama, Ohio, Oklahoma, and Tennessee. So pro-choice organizations and their attorneys fight in court against this type of violence by suing in Supreme Court and upholding Roe v. Wade. So for example, in April 2020, 20 women rights organizations, civil rights organizations, and human rights and reproductive justice groups together filed an amicus brief in the 11th Circuit Court of Appeals supporting the federal district court's decision to prevent Alabama's COVID order from denying abortion access. And as of the end of April, Alabama will continue to provide abortion services per the court order. So what about the clinics that are negatively impacted? What are the alternative ways that patients are seeking abortion?
So telemedicine essentially provides healthcare to patients through video consultations. They have been expanded under many stay-at-home orders across the country, and this is one way that abortions can be administered through medication abortions. Next slide. So this includes taking 2 pills. The first one is called mifepristone, which blocks progesterone in the body and prevents pregnancy from continuing. The second medication is misoprostol, which causes cramping and bleeding to clear out the contents of the uterus. Medication abortion in this way has been approved for use by the FDA since 2000. And these 2 pills taken together have a high success rate in ending pregnancy, and it has been shown to be as safe and effective as in-person abortions. And in fact, the fatality rate is lower than delivering the child, a child.
Okay, so now that we have a little bit of information and context about what an abortion kind of consists of, how does one kind of get one? So if we think pre-pandemic, it really depends on the state and it depends on what laws there are within that state. So in California, both teens and adults have the right to get an abortion up to 6 months up to 6 months after pregnancy. And according to Planned Parenthood, multiple clinics, including Planned Parenthood, can provide abortions both in pill form, as previously discussed, and in person at a clinic. So according to Planned Parenthood, an abortion pill or a medicated abortion, which was what was discussed previously, is offered up to 10 weeks and 0 days after the start of one's last menstrual period. And an in-clinic abortion is offered up to 16 weeks and 0 days after the start of one's menstrual period. So again, if we think pre-pandemic, what are kind of the barriers that existed for when women were trying to gain access to abortion services? Like I mentioned before, a lot of these barriers can come in the form of rule of law. So depending on what state you live in, the laws that around abortion access can really vary. So for example, in Texas, the law state, while abortion is legal, it bans women from receiving abortions 20 weeks into pregnancy. And there are a lot of other loopholes that women have to jump through, including how women have to receive a sonogram and be shown the images and a live heartbeat by the sonogram specialist, and the same doctor that performs the sonogram must by law perform the abortion. And then if we think about these barriers pre-pandemic kind of further, there's also a lot of social and cultural stigma and barriers to receive abortion. The process of going to an abortion clinic itself has a lot of stigma surrounding it, and even gaining physical access to a clinic, like having access to transportation, taking public transit. These can all be forms of barriers. So now that if we take all of those barriers and put them in the context of a pandemic, so the hoops that women have to jump through in the first place may not even be accessible. So if they have to go into a clinic to receive a consultation, they may not be able to do that now. And then if a woman lives in Texas and needs to get a sonogram, the service might not even be available. And if it is available, who knows if she'll be able to gain access to that because of a lack of transportation. So there are a lot of factors that need to be considered right now. So we believe that telehealth abortion access gives women the flexibility and assurance that they can receive the same level of care and get a proper abortion service without risking exposing themselves to the coronavirus. So what could that process look like? I kind of drew out a little bit of a map to visualize what that could look like. So a woman decides that she wants to explore abortion services. So she opens a healthcare app and schedules an appointment, a consultation. And this is kind of the first step where she uses telehealth medicine, where using her phone, she can schedule a consultation, and then maybe in that consultation they decide that a medicated abortion would be the best option for her. So she schedules a follow-up, and the physician puts in a prescription for the pills, and then within a week she receives those pills at her doorstep. And then she's able to receive those pills through her telehealth experience from the safety of her home without having to risk exposing herself to this virus. And through those same telehealth tools, she can schedule follow-up consultations to make sure that she's being safe and healthy throughout this process.
Yeah, so an aspect that also needs to get taken into consideration when talking about abortion is mental health challenges. And this could be in the form of stigma, this could be due to pre-abortion violence, like we talked about earlier. But basically, there exists a strong set of negative attitudes and beliefs towards abortion that makes it harder for women and girls to access and receive safe abortions. Because this could be in the form of loss of status, stereotypes, labeled as different, dirtiness, the list goes on and on and on. It has been shown that a person may battle between 4 types of abortion stigma. One of the ways that they can view abortion stigma is felt stigma. This could be an example of, I'm afraid I'll lose an important person. The second type is internalized stigma of, I feel ashamed like I'm a bad person. The third, stigma management. I need to hide my abortion for the people I'm close to. And 4, enacted stigma of the protesters at the clinic, people in my life, etc. call me a murderer. So this has extreme consequences in the sense that It creates a sense of shame and secrecy about the abortion, can resort to unsafe methods to get abortion, and therefore increase injuries or also possibly mortalities. Next slide, please. So how is teleabortion or telemedicine changing mental health? There's three prominent aspects that telemedicine and teleabortion is changing mental health, which can also be applicable towards the pandemic that we're currently in and after as well. The first one, which is the promotion of individual privacy. The second is reduced care cost. And the third is minimalization of stigma associated with abortion care. Next slide, please. So the first the first point is promotion of individual privacy. Now that we're in this pandemic and now that COVID-19 has hit, there's less individual privacy than ever before. You have people that are in their teenage years in a very confined household that have little means to have the time to go to a clinic or have the privacy or have the secrecy or whatever internal stigma that they're internally battling. It could be substance abuse, it could be religious conservative families. Telemedicine, teleabortion can be a very important tool that provides a positive alternative for them. Next slide, please. The next one is reduced care costs. It has been shown that with every single year, there is an increased cost of abortion treatment. So an average cost of a virtual visit via telemedicine is between $40 to $50, while the average cost of an in-person care visit can be as much as $176. And while the cost of in-clinic abortion can range from $350 to $950, the telemedicine can be about $95. This is extremely detrimental for the high rates of unemployment that we're seeing due to the pandemic and also the post-pandemic unemployment rates that we are also most likely going to have to struggle with as well. Next slide, please. And the last area is minimalization of stigma. Due to the pandemic, more people are realizing that telemedicine is an option. Before the pandemic, 1 in 10 people used telemedicine, but 75% of people were unaware. This fully shows that not only is telemedicine and teleabortion a very right and successful option for people that are in the pandemic, but also successful in that the word is getting out now, so then more people can utilize it later after the pandemic as well. This is a quote by Dr. Soon for her teleabortion trial in Hawaii, where basically what the article talked about is that in Hawaii, people had to travel on plane to different islands in order to get abortion care because specific islands had specific regulations. And she said, we're video conferencing with a woman who's sitting in the backyard and her kids are running around behind her. It says it's okay that this is happening. I think it really takes the stigma away from the abortion process. To me, this is very powerful because it shows not only can this be okay and provide the privatization and provide those three forms of stigma and mental health challenges that people exhibit with abortion and limit them, but it also can limit them for the future. And then next slide. And then these are the list of references that we used. And that's it.
My name is Jeff Koch, and our group is going to present on how the COVID-19 pandemic has altered human impact on the planet through emissions, agriculture, and working from home. Like I said, my name is Jeff Koch, and I'm a PhD student in soils and biogeochemistry at UC Davis, and I'll let the rest of my group introduce themselves.
Hi, I'm Tea Admitrai, and I go to UCR.
Hi, I'm Leslie Alfonso, and I go to UC Berkeley.
Hi, I'm Vandana, and I go to UCSC.
Okay, so
sorry, Dea. I skipped 2 slides. Okay, so yeah, so what's happening right now as a result of COVID-19 with the economy? So we're seeing many cases throughout the world. It's been considered a pandemic for a while. Over 5 million cases, 4.6 million. This was a few weeks ago though. But as a result, we've seen huge drops in the stock market, the biggest since 2008 recession and even bigger. Unemployment has skyrocketed to greater than 15%, and that's as of April. It's expected to reach 25% in some areas. Travel restrictions are now in place in over 100 countries. Air travel is down by 2/3 worldwide, and industrial production is down by more than half in many sectors. The current pandemic has disrupted everyone's lives, but some of the consequences have not been bad. Actually, they've been good for the planet. The slower economy has meant far lower emissions in many ways, and many of the changes have been just in how we live our lives. Many people are working from home, and we were interested in what the new normal might be like, and well, what the changes are and what the new normal might be like in the future.
Okay, so I will be discussing how emissions have reduced over the duration of quarantine, where our lives have come to a halt. Satellite images have shown that specifically in China, nitrogen dioxide, which is a pollutant released by the burning of fossil fuels and vehicle emissions, has significantly decreased, especially in the Wuhan region, as you can see in these satellite images. In China alone, there was a reduction of 200 million tons of carbon dioxide compared to the 2019 conditions. And obviously, due to the pandemic, flights have been canceled, and specifically in the United States, aircraft emissions account for 3% of total greenhouse emissions. So this is also a main emissions. Moreover, the demand for oil and coal has reduced because of factories and cars being less utilized. Next slide, please. So here are a few more images showing the temporary reductions of emissions. The estimated impacts of COVID-19 are significantly larger than past events and pandemics, as you can see by that chart. It could trigger the largest ever annual fall of carbon dioxide emissions. The second graph shows the decrease of real estate floor space sales, power plant coal consumption, container freight, traffic congestion, and air pollution, shown in the second image. And finally, the third image are satellite images of the East Coast before and after around March 2020 regarding the nitrogen dioxide levels. And so the main takeaway from these images is that although we have seen positive effects environmentally speaking, these results are only temporary, however, are proof that we as humans are the issue, and consistent, sustainable approaches will help keep emissions low. Thank you.
So I'll be discussing the impacts on the supply chain that coronavirus has had, specifically on suppliers. So when you look at global manufacturing, it's organized in global value chains, which is basically describing how like raw materials and products are manufactured, exported, marketed throughout various facilities in different countries. And China's at the heart of these global value chains. If you look at the graph that I've shown right there, it's showing how industrial production in China has dropped by 13.5% between January and February alone. And if you can see, like, there's like little drops within like 2002 to 2003, which was like SARS outbreak. And then even in 2008, which was like the financial downfall within like the US. And it just doesn't compare to the like massive drop that you see with coronavirus. And not to mention its impact on agriculture. So if you see the picture right there, that's just a huge surplus of onions. And so farmers are starting to see that they have this huge surplus that they can't sell, because even though a lot of people are going to grocery stores and they're cooking more at home, it just doesn't make up for the amount of like restaurants, hotels, and schools that are closing. So a lot of farmers are left to like dump or bury the crops that they have, and they're still planting for their next harvest, and they're not even sure if they're going to be able to sell that one. It all depends on how this pandemic continues. On to the next slide. And I also want to talk about workers in regards to this supply chain because that's also very important. So when looking at Amazon, there's been a lot of like outrage within Amazon workers talking about how the performance requirements that they have to uphold disincentivizes them to like wash their hands and to thoroughly disinfect work areas. And they also say that like Amazon doesn't communicate to its workers who has tested positive for COVID-19, and they often find that like local news sources are a lot more reliable to find out this information. And currently, if an Amazon worker has like symptoms that show that they're sick, but they haven't gone to get tested and show that they are in fact positive for coronavirus, they still need to show up to work. So that brings a lot of fear for a lot of workers. And they're currently having a petition between Amazon workers to try to push Amazon to kind of, put in more restrictions and really think about their health. When you look at grocery store workers, now they're seen also as essential workers. Obviously, grocery stores are still open. And even though stores are allowing employees to like wear masks and protective gear, they're often not providing that to their employees. And a lot of employees feel that even though there's like, you might see plexiglass, it's kind of dividing you from the worker, or there's like sometimes in some stores they're disinfecting certain areas or they're enforcing social distancing. They don't think it's like enough, and they don't feel that it's enforced as much either. And another sector, going back to agriculture, is the farm workers, those who actually work in those fields. A lot of them are undocumented, they lack health insurance, they don't qualify for unemployment or for the COVID-19 relief. So there's a workforce of 420,000 people who are left vulnerable. And it's important to also remember that although these are Latino workers, a lot of the times they don't even speak Spanish. Sometimes they might speak an indigenous language. So trying to communicate, these are the types of new regulations we need to enforce. This is what you need to look out for. It's hard when there's that language barrier. And they're still paid by piece. So that means that they're not paid an hourly wage. They're paid on what they pick. So telling a worker, oh, you need to take time out of your day to wash your hands constantly or to make sure you keep social distancing, they're not going to be incentivized to do that when time really is money for them.
Yeah, I'm going to be talking about how travel has really gone down recently due to COVID-19. So basically, I wanted to talk about leisure travel in general first. Leisure travel has actually dropped down greatly due to safety measures and other reasons. As seen in the picture below, there haven't been a lot of passengers actually going onto airlines due to quarantine and so on. So actually the prices actually went down from $680 to $205 in domestic travel round trips around, or even in general. For example, international flights have actually been canceled for a lot of for safety measures. Global tourism has also been affected greatly, and a lot of countries actually depend on this economically due to like in terms of, for example, Italy almost lost 7.7 billion euros from tourism due to the high amount of cases that has arisen in Italy. Also, Vietnam and Indonesia have also decreased by double digits in tourist arrivals, and their economy kind of depends on the money that is coming through tourism as well. Business travels as well have dropped down. South Korea actually has the most highest business travels for 2020, and they had a 55% impact of these plans due to cancellation, postponing, and etc. Commuting to certain places, for example, public transports like buses, trains, and any source of public transport has actually been completely either shut down or either used only for specific purposes. Like, for example, Israel has completely shut down, and they've only allowed these transportation within cities only if necessary. Also, another country would also be India. So they also have shut down completely all transportations and they have only opened up certain buses and trains for actual immigrant workers to get across to get home. Lastly, I wanted to talk about conferences that have been scheduled this year and have been postponed and canceled. So a lot of the conferences that such as like medical conferences, business conferences have been really they have dropped tremendously. Like in terms of like postponing or either canceling, and they've used a lot of online platforms in order for these to occur. So it's almost 66% have postponed their gatherings, and around like 41% have canceled, like such as medical conferences, and 5% is about online. So a lot, depending on the conference, they have also been canceled. So as a whole, you can really tell like the travel and commuting has really dropped down, as mentioned by Thea. Like the emissions have also, like the carbon dioxide and all of these like kind of correlate to each other, and like due to the reductions in travel, that also led to the reductions in CO2 emissions and so on and so forth.
So these statistics have caused us to ask some questions. Obviously, the pandemic is hopefully going to be limited to the next, 6 months or a year in the bulk of it. But what's the new normal going to look like? And are things going to completely return to normal? Or are some of these changes going to be more permanent? So having worked from home and or used online communication tools to maintain, semblance of their previous lives, how many workers are going to continue using these tools? I know that, just speaking for myself, I've been to a ton more webinars, some online conferences. We're doing this. This is an example of something that was going to be in person and now is online. And we've just seen this huge reduction in business travel and commuting. And even Google has said that through the rest of this year, there's going to be, the workers are going to be working from home. So even if you just think of one giant workforce and a lot of those people not commuting anymore, that's a huge reduction in emissions. Like my colleagues have said, many conferences have moved online, and there's an increase in the offer for webinars and public outreach in digital forms. And I personally think that there's a lot of this is going to be a shift that's not going to completely go back to normal, that we're experiencing some of this and getting used to it. And there were changes that may have taken a lot longer, but they're going to happen, and a lot of them are going to stay. Another thing to think about is schools. We're all in or involved in college, and a lot of colleges are making decisions right now about how they're going to educate students next year to reduce travel. A lot of schools are offering online degrees, and the enrollment is jumping dramatically in those online programs, so students don't have to travel. And then even the schools that are still going to do in-person classes are changing the format to where there's going to be less travel back and forth from from their hometown to school in order to prevent the spread of coronavirus. Some of those things may stick around, is what I hypothesize. And then finally, will people return to shopping in brick and mortar stores at the same rates as before? I know that a lot of people are still ordering from Grubhub, they're ordering from Amazon, they're getting groceries from Instacart. How many people are going to continue using those tools after this is over? That's something really interesting to think about. So that's all we have. We have some sources here, and thank you.
Thank you all.
Okay, hi guys. My name is Sydney Adams from UC Merced.
Hi, I'm Colette, and I'm from UC San Diego.
I'm Mary, and I'm from UC San Diego.
My name is Norhan, and I'm from UC San Diego as well.
And I'm Rebecca, and I'm from UC Berkeley.
Yeah, and today we're going to be talking about pregnancy and prenatal care during the COVID-19 pandemic. Next slide. Okay, so the reason we're talking about this and the significance of this whole topic is that pregnant people are at a higher risk since pregnancy is an immunosuppressed state. As we all know, when women are pregnant, their bodies are going through a lot of changes and they must take care of themselves to the best of their abilities in order to keep the baby safe. Newborns are more susceptible of getting illnesses as well once they are born. And there isn't a lot of research on this, or for COVID specifically, but we all know that diseases can be spread from mother to baby in the womb. COVID-19 has taken away many of the joys of pregnancy, especially for new mothers. You know, with baby showers being canceled, people can't really do their gender reveals, and going to the doctor every month or, you know, every week when it gets to the last stretch. New moms aren't able to do this, and it's not so fun. So, and then prenatal care is crucial and essential for all pregnant people. So, yeah, you must go to the doctor if you're pregnant. So, and unfortunately with the pandemic, that doesn't mean that people can just stop having babies, you know, life must go on. So yeah, next slide. Okay, so key takeaways, all of us did some research and we just kind of pulled from multiple articles that we found. Many doctors and OBGYNs are making accommodations, having curbside appointments, which I thought was really interesting, as you see in that first picture. Telemedicine, fewer appointments, so doctors are only seeing their patients at, and this is some doctors, this isn't all, doctors are seeing their patients at week 28, 36, 39, and some of them are doing video appointments for the other weeks. And the curbside appointments seem to be, they seem to be really interesting because you're able to do a lot of things, but it's still kind of contact. It's really interesting. And then they're also doing virtual breathing and birthing classes, which I thought was fun. Not the same, you know, it's not the same vibe, but you know, it's getting the job done. Surrogates are, oh, this was fun. Not fun, but it's interesting. Surrogates are unable to give babies to the families that they are carrying the children for. So for example, if a surrogate is having a child for
Sydney, your video froze. You might turn off your video and keep on your audio. That sometimes helps when you freeze. Because we can't hear you, Sydney.
In the meantime, Norhan, do you want to maybe go to the next slides and then have the next group go or group member go?
Sydney's back.
Sorry guys. My Wi-Fi's been a little crazy today. Okay, and lastly, there's been an increased demand of midwives and doulas. So I believe in the first presentation that was given, they were talking about how they're making a shift to home births. And with that, we need more midwives and doulas. So that's another thing that we found. Cool.
Hi. So yeah, speaking of the significance, with like 250 babies born every minute, it's safe to assume that about 24 million new lives have started since we've kind of entered lockdown 10 weeks ago, at least in the States. But this is like a world number. And just thinking of like the life course model and the critical period that pregnancy is, we kind of looked into the effect of COVID-19 on the timeline of care for birthing persons, with changes at all stages, which you can kind of see here in our timeline. And what we really noticed was the emerging role of telehealth, especially with new federal changes that allow providers to bill patients for virtual services. And this kind of brought up certain key issues. So around access, using telemedicine requires access to the device, internet connectivity, technical savviness, and not all patients have that, but at the same time, it might be more inclusive for those who live in remote or rural areas and might actually pave the way to improve medicine in that respect. Cost is also a certain issue. Obviously, with telemedicine, many blood pressure cuffs start at about $25, and fetal heart rate monitors are not covered by Medicaid. However, there's reduction in maybe transportation costs. Efficiency, families are dealing with like lack of childcare, and so being able to just like FaceTime your provider might be really efficient. However, when we think of preventive care for disorders like preeclampsia, which kind of go unnoticed, especially in the third trimester, it might create issues. And lastly, with quality, in the articles that we read, one of the things that a lot of patients were concerned about were that regular prenatal care in this country, at least in the US, already feels like it lacks connection is really impersonal. And so how do you maintain that at the same time? And next slide.
Hi everyone, so now we kind of wanted to get a more detailed view of what this looks like across countries, not just in the US. So first of all, in China, where the coronavirus hit first, they had the most limited information about the virus, how it was transmitted, and what that exactly meant for pregnant mothers. And this was especially emotionally taxing on the mothers in China because they had very little information to guide them throughout their pregnancy, and they didn't know what would happen after they delivered. Because there was so much unknown during this time, the newborns were immediately separated from their mothers at birth and cared for by other nurses. And you can kind of guess how this might affect the bond between mother and child, and how this might be emotionally traumatizing for both the mothers and their children. And then next, we wanted to look about where the virus is currently spreading, which is towards the south. And in Mexico, the first 2 pregnant women died last month from coronavirus. And since then, they have found that of the pregnant women that have died, they have had either hypertension, diabetes, or were obese. And this is especially troubling because the United States and Mexico have both been found to have very high rates of diabetes and obesity, especially in the low-income areas. And then next, in Switzerland, they chose to inform all mothers of the risks of breastfeeding and bonding with their babies, but ultimately they leave the choices to the mothers because mothers might want to have the lifelong benefits of breastfeeding. So I thought this was an interesting dynamic between what was happening in China and what they're doing in Switzerland. And then finally, we talked a lot about how telehealth is essential right now and how that's changing the climate of what's happening with pregnant mothers. But in countries where telehealth isn't accessible, patients might have to weigh out the risks and benefits of going to doctor's appointments. And in places where hospitals aren't accessible, having home births is much more common.
So we also wanted to look at the mental health considerations of COVID-19 in prenatal care. So with changing hospital policies consistently, especially for visitors and the limitation of visitors, pregnant people may not have full support systems when they expected when giving birth. So as you mentioned before, this has caused an increase in demand for home births and in turn an increase in demand for doulas and midwives. And also people are more hesitant to give birth at hospitals since the risk of infection, and there's so many changing policies. The prenatal care aspects of social and emotional support has also been affected since a lot of times pregnant women have social groups they see every week that really help their pregnancy and their mental health. And now that restrictions have been in place for shelter in place, that has been eliminated. And this is especially detrimental for women of color as we can see mortality rates are higher for women of color, and we've seen that social support can help change that. So separation from other family members is also crucial due to restricted traveling and the cancellation of flights. And postpartum depression is the most common complication for women who just have had a baby. It affects about 15% of people who give birth, and this will most likely increase due to the induced stressors of the pandemic. So next slide.
Some questions that have arose after the COVID-19 pandemic has started about pregnancy include: will mothers be at risk if they spend more time in the hospital after they give birth? And what are the effects of COVID-19 on the fetus, and if there's any effects in the development of the fetus? And will changes to prenatal care affect well-being of pregnant women and their fetuses? So research is currently just starting about the effects of COVID-19 on pregnant people. So right now there's the priority study at UCSF, which is a nationwide study that is being implemented to better understand how COVID-19 affects pregnant women and their newborns. So the COVID-19 pandemic has changed the way that prenatal care is being carried out, and some of these changes might be here to stay. So a lot of physicians are now discussing whether frequent appointments are really as necessary as in the US. The average number of prenatal appointments is about 11 to 14, but the World Health Organization recommends 8, and the increased amount of prenatal appointments hasn't really improved pregnancy outcomes in the United States. The United States actually spends the most on pregnancy, but the outcomes are not as good as some of the other developed countries. And also now, due to the COVID-19 pandemic, there's an increased use of telehealth and telemedicine. So going forward, we might see more telehealth appointments being implemented in prenatal care. So right now, there's the tele-OB program at UW Medicine that might be replicated in health systems across the US. That's basically a program where an expectant mother is given a fetal monitor, and they are also required to monitor their blood pressure and keep a log of any symptoms that may arise during the pregnancy. And they also have a couple of online call appointments with their providers. But this has implications for prenatal care access, because it can both increase and decrease access to prenatal care for some people who can't take time off to go to a prenatal care appointment, or for people who live in rural areas, this telehealth model might be a better choice for them. But for people who don't have access to reliable internet access or devices that will allow them to communicate with their providers, it presents more of an obstacle for them. And especially for the people who are financially vulnerable, since they might not have access to these devices, they might be more at risk, because a lot of these women also suffer from other underlying conditions, and they are more at risk of certain complications such as preeclampsia. Also, these changes in the way prenatal care is approached could lead to pregnant women feeling more empowered in a way. So like as I mentioned, by the OB program that allows pregnant women to basically take control of their pregnancy and keep track of any symptoms that arise, and keep track of their baby using the fetal monitor, that basically could empower them in a way. Also, there's been some changes recently in the involvement of mid-level practitioners in healthcare in general, and which might also affect prenatal care, because now midwives and nurse practitioners and physician assistants, they might be able to have more autonomy in terms of monitoring pregnant patients and providing prenatal care. And these are references. Thank you.
Awesome job.
So our presentation is on Title IX. Okay, so what is Title IX? So according to Title IX, no person in the United States shall, on the basis of sex, be excluded from participation in, be denied the benefits of, or be subjected to discrimination under any education program or activity receiving federal financial assistance. Okay. So Title IX is meant to ensure that educational institutions are operating in a non-discriminatory manner, and it includes local school districts, post-secondary institutions, i.e. colleges and universities, charter schools, for-profit schools, libraries, museums, and rehab agencies. And so these rules should apply to things such as recruitment, admissions, counseling, financial assistance. Our presentation today is mainly focused on Title IX in regards to sex-based harassment. And so on May 6th, earlier this month, Betsy DeVos, who is the head of the education department, announced that there are now new legal requirements for how universities must handle issues regarding sexual assault and harassment. And these new requirements are kind of concerning because we're worried about victims and whether or not they're going to have adequate protection.
So who is affected by these new provisions? In short, anyone who goes through the Office of Title IX and attends institutions federally funded. Specifically, we want to focus on effects of those provisions with victims and sexual harassment and assault. What's striking and significant about these provisions is that they're allowing things that were previously prohibited under the Obama administration. And what might these specifically include? These might that within the Obama administration, it was stated, it's believed that the compliance to Title IX required the use of preponderance and the standard for sexual harassment cases. And it might include and will lean more towards higher standards of evidence, especially when the Obama administration enacted these requirements, because any higher requirement, i.e. such as high clear evidence introduced, may by design tilt towards those of who were accused. Notably, the provisions may favor informal resolutions such as mediations, and what we want to highlight is the possibility of live hearings and survivors potentially seeing and confronting their assaulters that can and may result in victims choosing to go informal or not come forward at all. So what are some of these key provisions? I would like to read all of them, but since we are kind of on a time crunch, I believe that Alexis might have these slides and can be viewed and looked at later on. So I'm gonna go past this.
Okay, so the provision that I will be discussing with you all today is the claim that these amendments to Title IX will restore fairness on college campuses by upholding all students' rights to written notice of allegations, the right to an advisor, and the right to submit, cross-examine, and challenge evidence at a live hearing. This provision in particular is most alarming to us because, in short, this provision now requires a cross-examination of a survivor to be conducted. Sexual assault, as we all know, is not a light matter. So for survivors, these cases are extremely traumatic and distressing. So for DeVos to disregard the sensitive nature of these cases is just cruel and unjust. And as a survivor myself, I strongly believe that no one should have to speak about these experiences to then be relentlessly cross-examined on the stand. As Greta Anderson from Insider Higher Ed states, different people respond to trauma in different ways, and it would be hard to gauge whether the victim is being genuine enough. The justice system must uphold its standard that individuals are innocent until proven guilty. By raising these standards, survivors are now guilty until proven innocent. This new standard will inarguably prevent survivors from coming forward. According to the Department of Justice, 80% of sexual violence cases go unreported. Women tend to avoid filing reports out of fear or embarrassment, coupled with the notion that nothing can be done to help them. Already, this is a constant battle, especially at college campuses. These new provisions to Title IX is a complete step backwards, and that's what's most saddening. As a student, I want to be on a campus where the administration appropriately supports survivors and encourages them to come forward. I also know that there are many others who share these same concerns. It saddens me that there are claims that these new regulations are intended to strengthen Title IX protections for survivors, when in reality, all these regulations do are weaken these protections. In the following slides, we've gathered statements made by the UCs regarding these changes. In order to respect time, we're not going to be reading all of them. We will just go through them, and then when you guys have time, you can look back at the recordings, or we can share these slides with you all. So in essence, all of the schools have made some sort of comment besides, I believe it was UC San Diego, and I don't recall the other school off the top of my head. Maybe one of my peers could chime in.
UCLA?
UCLA did make a comment.
Okay.
So there were some schools that made some really heartwarming comments about Title IX, but then there were also others that just said, okay, we're going to comply with these new changes. So we really, because we are all come from different UCs and we're here together, we wanted to include different opinions and discussion of this topic. And it's just really sad that these regulations came into place in the midst of a pandemic when not everybody's at school, everybody's preoccupied by what's going on by them, that they could just get this past us without us noticing. So we just urge you all to look into this and to really ask your peers and bring up conversation and dialogue about this topic, because it's something that can significantly impact everyone around you. And I think it's important that we all become educated and well-versed on what our rights are as students at these schools.
Yeah, and that's it.
Thank you.
Of course.